I'll start to speak a little bit about what is arthritis in children. So when we speak about arthritis, sometimes doctors have different meanings, and they have some words that uh, we use that may be misleading, or the family may have some doubts about it. So when we talk about arthritis, we talk about inflammation in the joint, and that's different from arthralgia. So arthralgia is having pain in your joints. Arthritis is more than that. So you have an inflammation in your joint, and that inflammation will give you different things, also arthralgia. So when you have arthralgia, when you have pain in a joint, you can have it because you have inflammation, or you can have it because of several different reasons. But when you have arthritis, you have usually joint pain. And the children that have juvenile idiopathic arthritis, that have chronic arthritis, usually the pain is not very severe. Sometimes we think when we have patients with arthritis that they are going to have very severe pain, but in a scale of 1 to 10, usually the pain of chronic arthritis is more like a 2, a 3, a 4, but it's certainly not a 7, an 8, or a 9. So different types of situations and conditions are going to give different intensities of pain. So it's very common that a child, mainly little child, is going to have chronic inflammation of a joint, chronic arthritis, and they are not going to complain. They are not going to say, oh, my knee hurts, because it's a very mild but very chronic pain. And usually what the child does is that they don't use that joint, and they are going, and sometimes they limp a lot, and they just walk in a funny way because they have pain, so they don't use that joint so much. So when we think, oh, the child is not complaining, that's because they don't have active inflammation. That's not true. Sometimes they don't complain, but they still have arthritis. So the signs of having arthritis, of having inflammation in a joint, are of course the joint pain, that, as we have been discussing, could be sometimes mild, and the swelling. Sometimes the child will have a massive swelling with not so much pain associated. And the swelling, as you can see in the picture, the swelling is because there is an increase in synovial fluid, and also the inflamed synovial membrane. So the joint is going to be full of liquid and full of this membrane that is going to be hypertrophic, and there is also overgrowth of the bone, so the joint will get swollen. So the swallowing is really important. Sometimes you can notice that the joint is also warm. It could be mild, the difference, but it makes perfect sense because it's inflamed. Regarding the redness of the joint, usually you don't see it with the chronic inflammation of the joint. You see it with a septic arthritis. So if the arthritis is full of bacteria and you have lots of inflammation, sometimes they are red. In these conditions of chronic inflammation, the redness is not so frequent at all. And then we have the morning stiffness. So when you have an inflammatory pain, usually the patient and the child is going to complain that in the morning they are more stiff. It's more difficult to walk, it's more difficult to move. And when through the day, they are going to get better and better. And if they are for 2 hours at their desk reading, and then they start moving again, they will have again stiffness. So this is the characteristic of an inflammatory pain, which is different from a mechanic pain. And another sign of arthritis is the limited range of motion. So that's something that a pediatric rheumatologist always evaluates in their physical exam to know if there is or there is not a limited range of motion. So in a child, if we have a chronic inflammation of the joint, then we'll say that we have arthritis, and we have this condition called juvenile idiopathic arthritis. So when we think about arthritis in a child, we can have lots of different reasons to have arthritis. Some people will have arthritis because they have infection, they have a bacteria in the joint. Other people are going to have arthritis because they had an infection, a viral infection, or a bacterial infection, and they just react and they have inflammation in their joint. But when the arthritis is chronic, when you have more than 6 weeks of duration, then we talk about this juvenile idiopathic arthritis, that we usually say that the onset is before 16 years old. And then you know how doctors are. We like to categorize the diseases and subclassify the diseases to help us tell the patients what is the prognosis, and try to do it in a more personalized way, and try to do treatments strategically to different types of juvenile idiopathic arthritis. So we divide it in oligoarticular and polyarticular. The oligoarticular arthritis, it's defined by a child or a teenager that has arthritis, so chronic inflammation of the joint more than 6 weeks in 4 or less joints. And then we are going to see if it's persistent or it's extended. What does that mean? If the patient doesn't have inflammation, doesn't have arthritis in other joints, then it's persistent. Then if it has more arthritis cumulatively over the years, then it will be oligoarticular extended. So when we talk about oligoarticular, we are talking about a smaller number of joints affected. When we are talking about polyarticular, then we have more than 4 joints, so 5 or more. And then we subdivide these if they have rheumatoid factor positive or negative. And this helps us to understand what are the different risks, what is the odds of progressing through adulthood, what is the possibility to be a chronic disease, what is the possibility to get better early. So we like to subdivide the juvenile idiopathic arthritis in different types to help in terms of treatment strategies and in terms of prognosis. And one of the things, can we change slide? Thank you. So one of the things that I would like to tell you, and it's relevant for what we are also discussing today, is that children that have arthritis, they might have uveitis also. So uveitis is the inflammation of the eye, of the uvea of the eye, and usually they have anterior uveitis, which is this cambra on the anterior part of the eye. And it's the percentage of children that can have uveitis, children with juvenile idiopathic arthritis that can have uveitis, is quite high. So it's 11 to 30% of the children with juvenile idiopathic arthritis can have uveitis. And this can happen in any type of juvenile idiopathic arthritis, but particular the children that have oligoarticular, so that they have a lower number of joints affected, and particularly the ones that have anti-nuclear antibodies positive, they have a really high risk of developing anterior uveitis. And another very important thing to think about is that this chronic anterior uveitis is usually asymptomatic. So initially, the child is not going to have redness of the eye, doesn't going to have differences in the visual ability. So the child is going to be wonderful. They are not going to complain about anything in their eyes. The parents are not going to see any difference, but they can have active uveitis. And if not treated, this can be really disabling and can cause visual disabling complications. So it's really important to screen these children. And for instance, the children that have juvenile idiopathic arthritis, oligoarticular with these anti-nuclear antibodies positive, they have to go to the ophthalmologist every 3 months to make sure that they don't have the uveitis. So as you can see, we have an inflammatory process in the joint, and some children will have it also in the eye. So there is a common ground of inflammation between what happens in the joint and what happens in the eye. We can also change. So I discussed previously 2 types of juvenile idiopathic arthritis, the oligoarticular and the polyarticular, but there are many more. So another type of juvenile idiopathic arthritis is called the systemic juvenile idiopathic arthritis, and recently the nomenclature changed. Now we call them this Still's disease. It's a little bit different. It's an autoinflammatory condition, and these children have fever, long duration of fever. They have a rash, mainly when they are with fever. It's the salmon rash. And they might have enlarged lymph nodes and enlarged liver and enlarged spleen. So there is this autoinflammation, and inflammation in the body that is not controlled. And sometimes it's so active that can give a macrophage activation syndrome, like a cytokine storm. The child might be really sick. And for these, sometimes the children have all these symptoms and they don't have arthritis, and this is still disease. So this is a kind of a different type of arthritis that when it happens, you can have arthritis and these symptoms, or you can have only these symptoms without arthritis. Then we also have psoriatic arthritis. also a little bit different. So sometimes the child has psoriasis and has arthritis, but they might only have arthritis and they have, for instance, a first degree relative with psoriasis, and that is also helpful for the diagnosis. This child can also have uveitis, but usually symptomatic, not as symptomatic like we have seen before. And then we have the enthesitis related juvenile idiopathic arthritis. And here they are mainly boys, or more common in boys than girls, usually more than 6 years old, and usually large joints are more affected than small joints, and it's very common to have enthesitis at the same time. So enthesitis is the inflammation of the entheses, and the entheses, as you can see in the picture, are the site where the tendons and the ligaments and the joint capsules attach to the bones. So this can also be inflamed, and this can be very limited of the life quality. So usually these children also have sacroiliac joint tenderness. They might have inflammatory back pain. They can be HLA-B27. And it's very interesting that these patients very often have inflammatory bowel disease. So the connection between what's happening in the bowel and what's happening in the joints, here it's quite common. So we have been discussing what is arthritis in children, and we have been discussing the types of juvenile idiopathic arthritis, but arthritis can also happen in other diseases. And one of the diseases that is common, it's lupus. So lupus in children is less common than in adults, of course, and as you know, it's a systemic disease. And arthritis is one of the manifestations. And it's very common that the arthritis has more pain than what we can see in terms of the physical examination. So sometimes the patients say that my knees really hurt, my wrists really hurt, but then on the physical examination, the swelling is not so visible like it is, for instance, in juvenile idiopathic arthritis. But these patients might have involvement of the different organs. Sometimes these children have weight loss, fever. They may also have enlarged lymph nodes, enlarged liver, and enlarged spleen. The fatigue is really important in some patients, and of course skin manifestations. They might have a malar rash, they might have oral and nasal ulcers, they have myalgias, and they have hematological manifestations. Anemia, leukopenia, thrombocytopenia are quite common. The heart involvement is very variable. You can have pericarditis, myocarditis, endocarditis. Everything can happen in terms of the heart, and in terms of the lungs, the pleuritis is the most common manifestation. And of course, pulmonary bleeding is one of the most fierce complications. Then you can also have involvement of the central nervous system and the peripheral nervous system. And the renal involvement is going really to be important for the prognosis. And in children, it's much more common than in adults to have the renal involvement. And this is, of course, it's really important to have a treatment strategy to control it so that there is no progression to end-stage renal disease. And with the drugs that we use now, the majority of the patients, we can control the kidney involvement, but of course, it's necessary to have a very good screening, follow-up, and a correct treatment strategy. So we have been discussing in children what are different causes of arthritis. And of course, this is what it's important for ENCA and for the families that are here today. We discussed juvenile idiopathic arthritis, we discussed lupus, but we have many more diseases that any autoinflammatory disease, immune-mediated disease can have arthritis as one of the manifestations. But what we wanted to tell is our main interest in terms of research, that is how the diet and the microbiota can affect the manifestations of the disease and what was going on. So when we think, for instance, about lupus, there is all this dysregulation of the immunitary system. So in lupus, the patients have autoantibodies, so they have antibodies against antigens that are self-antigens from the person, which is not what we should have. And you have all these different cells of the immune system that are going to be dysregulated, and they are going to be activated, and they are going to release substance that are going to be pro-inflammatory. So one of our ideas of what could happen in terms of the pathogenesis of the lupus was that what we eat and our lifestyles, and we can go to the next slide, So our lifestyles, what we eat, our physical, if we do or not exercise, and what is our body composition, this will for sure affect the gut microbiota. And the gut microbiota is going to determine what's going on in terms of the immunity of our gut, and it's going also to affect the gut permeability. And if you affect your gut permeability, there are more substances that can go through the lumen of the gut to the blood, and this could be one of the multiple causes of these immune-mediated diseases that is going to help to chronically activate the immune system of these patients. So for sure, this is not a cause-effect thing. It's not, oh, diet is affecting my child and diet is the cause of my child's disease. That is not the case. But what is our hypothesis is that diet and gut microbiota and gut permeability is also going to be a factor that is going to influentiate the activity of the child. And that's the hypothesis that we are testing. So for sure, once again, that is not a cause effect. It's not the diet that caused the disease, not at all. We know this is a multi-hit disease, so there are particularities of the genetic background, and also what is the environment and epigenetic changes, and all of that is going to be important for the mechanisms of the disease. And of course, our lifestyle is going to also modulate what is going to be the activity of the disease. So what we are studying is how these different components can influentiate the activity of these different diseases. And we did that for lupus. And what I'm showing you in the next slide are the results of the study done by two master students, Miguel Castro and Inês Correia. Inês is going to speak also afterwards. And we study in lupus patients in healthy controls their diet, their physical activity, and what was going on in their gut. So if you follow me, so you have this chart that is blue and red. You can see if the patients were adherent or not to the Mediterranean diet. And you can see that the lupus patients had insufficient adherence to the Mediterranean diet compared to the healthy controls. And the lupus patients have less consumption of fiber than the healthy controls. And they also had more consumption of the omega-6 fatty acid than the omega-3. And the omega-6 is pro-inflammatory and the omega-3 is anti-inflammatory in a very simplistic way. So we have a diet that is not the diet that we would like for these patients. Then here on the other chart, we have the IPEC. The IPEC, it's a questionnaire that we use to understand physical activity, and the lupus patients had much less physical activity than the healthy controls, which makes perfect sense. And here we are talking about patients that are in the pediatric age range and adults. So we have both of them in this group. And of course, if you have arthralgias, if you have fatigue, it's more difficult to have correct physical activity. But we also know, on the other hand, that one of the aspects that improves fatigue the most is really physical exercise. So it's highly recommended that children with lupus do physical exercise. Then the other chart shows the sitting time, which is higher, significantly higher in lupus patients compared to healthy controls. And then finally, we have the fat mass, the percentage of fat mass that was higher in lupus patients compared to controls. Then we studied also the gut microbiota, and patients with lupus had less diversity of the gut microbiota. And the diversity of the gut microbiota, it's a broad measure of the health of your gut microbiota. So if you have less diversity, it's not good. So the lupus patients had less diversity. And then we have the lactulose mannitol test. So we ask our patients to fast for 8 hours, and they drink lactulose and mannitol, and which is a drink of sugars. And we are going to collect their urine for 4 hours, and we measure these sugars in the urine. And by measuring in the urine, we can say if they have a leaky gut or not. How is their gut permeability going? And the lupus patients had higher gut permeability compared to controls. So our main hypothesis that we are going to see in the next slide is that in lupus patients and probably in other conditions with arthritis, we are going to have dysbiosis. So there is the harmony of the healthy gut microbiota is not established, and this dysbiosis is going to increase one protein that is zonulin. So zonulin is this protein that is going to be sensed, and it's going to cause a disassembling of the cells in the gut. So it's going to open the gut. And then when you open the gut, you have substance from the lumen of the gut, from the bacteria that are in the lumen of the gut that can enter, and they can go through the bloodstream or they can go through the tissues. And our hypothesis is that this is also helping in the chronic activation of the immune system.